Hello, everyone, and welcome to another CEU presentation for 2025 Care for You 2. My name is Jessica Doan. I'm a licensed clinical social worker here at Resolve Counseling and Wellness. I'm also the Director of Community Engagement and a clinician here. For our topic today, we are going to be discussing adjustment disorders, diagnosis, as well as some treatment modalities and methods that may be helpful to try out. Before we dive in today, though, I'd like to start with a question. I want you to ponder a little bit to yourself. Even pause the video if you need to. I know we just got started, but it's incredibly important that we set the stage for this. So I want you to think to yourself, have you ever found yourself second guessing a diagnosis that you give a client, even after many sessions of assessing them? And on the other hand, have you ever found yourself diagnosing this disorder, adjustment disorder, too often when you feel like there might be another diagnosis that could be more specific? So, again, I'm going to ask you to pause and think about that for just a moment. If you answered yes to either of these questions, I first just want to let you know that you're not alone. Adjustment disorder is something that is sort of overly used, not used enough. You're not sure when and where, how or why. And I'm hopeful that throughout our presentation today, I'm going to be able to give you a little bit more information on really what this disorder looks like and when it would be appropriate to diagnose someone with something like adjustment disorder. So we've got our objectives here. Our main goals are going to be to look over the history of adjustment disorder through the DSM. So I'm going to go through many different versions of the DSM, starting with DSM-1, and then we're going to work our way up until the DSM-5-TR, which is our current version of the DSM. It's really fascinating to see how this diagnosis has evolved and changed over time. Then I'm going to go into the definition of current day adjustment disorder, what this looks like, and what that criteria is. We'll go through the DSM-5-TR criteria and the different specifiers. We're also going to look at some differentiation between other diagnoses that may show up similarly. I'm going to go through some assessment tools that are options for you to utilize, and then some different treatment modalities if you come to the place of, okay, the person I am working with does in fact have an adjustment disorder. So buckle up because we have quite a bit of content to review in the next hour. I'm going to encourage a couple of different times throughout the presentation to pause and think or pause and evaluate. So please feel free to do so. As always, when discussing diagnosis, I'm going to be sharing some factual information. We can't say it's a one size fits all, and I think that that's important to keep in mind as we're reviewing some of these case studies and differentiations. So, starting out, I mentioned we're going to go through the history of adjustment disorder through the DSM, the origins of the diagnosis, and the evolution of the criteria over time. As I mentioned in the very beginning, this part of the research was very, very fascinating, just to see how this particular diagnosis started out, where it came from, what the roots were, and then how it's ebbed and flowed over time. Um, Starting us out first with the DSM-1, this was um, this was published in 1952. Adjustment disorder was referred to something called transient situational personality disorder. I'm going to say that again. Adjustment disorder started out in the DSM-1 in 1952 as a personality disorder. When I think of adjustment disorder today, personality disorder does not at all come to my mind. More so things related to stress or post-traumatic stress, situational items. Those are the things coming to mind. So when I first learned that the very first time that this idea was presented as a situational personality disorder really blew my mind. This started from a view developed during World War II that psychological symptoms related to combat experiences were normal responses to abnormal situations and transient unless treated in ways that increased secondary gain. So essentially, much like PTSD, in 1952, it was determined that folks that were in combat were having responses to stress. It was also noted that the type of stress that they were under in World War II was abnormal. It was an abnormal type of stress that your day-to-day person wasn't experiencing. So, what's also interesting here in 1952 is that the diagnostic categories were based on developmental stages, not based on the event, the situation, or the symptoms, which I think is really fascinating. So, you'll notice here on this list some of the different subcategories of transient situational personality disorder included adjustment reaction of infancy, adjustment reaction of childhood. And then you'll see a couple of broken down pieces there. So in childhood, is there a habit disturbance, a conduct disturbance, or are there neurotic traits? Then it also goes further into reaction of adolescence and adjustment reaction of late life. Thinking about this, we know as human beings that each phase of life does come with adjustment. So it's really interesting that this was set up, like I said, as a personality disorder. So if we read this classification here, it says this general classification should be restricted to reactions which are more or less transient in character and which appear to be an acute symptom response to a situation without apparent underlying personality disturbances. Whew. The symptoms are the immediate means used by the individual in his struggle to adjust to an overwhelming situation. In the presence of good adaptive capacity, recession of symptoms generally occurs when the situational stress diminishes. Persistent failure to resolve will indicate a more severe underlying disturbance and will be classified elsewhere. So you'll see here they're saying if you're having stress related to an abnormal situation, if you get out of the abnormal situation, it's likely that the stress and the symptoms will magically disappear. It's also saying here that if they don't magically disappear, there's obviously something wrong with you, and we need to put this underlying disturbance in a different classification. Um, we're going to talk a little bit more about this as we go through the different years. But again, this is our baseline. This is our starting point. If you know anything about adjustment disorders in 2025, you know that this is quite different. So let's keep going. Next, we've got the DSM-2, which came out in 1968. So we're more than a decade out from that first definition. And now this is called the transient situational disturbances. So it's no longer a personality disorder. Now they're saying, all right, these are disturbances that are situational. So, this major category is reserved for more or less transient disorders of any severity, including those of psychotic proportions that occur in individuals without any apparent underlying mental disorders that represent an acute reaction to an overwhelming environmental stress. A diagnosis in this category should specify the cause and manifestations of the disturbance so far as possible. If the patient has good adaptive capacity, his symptoms usually recede as the stress diminishes. If, however, the symptoms persist after the stress is removed, the diagnosis of another mental disorder is indicated. Disorders in this category are classified according to the patient's developmental stages. And those developmental stages were broken down into 5 stages, much like in the DSM-1. So we've got infancy, childhood, adolescence, adult life, and late life. Um, so if we're looking here and comparing between the DSM-1 and the DSM-2, we're in a pretty similar spot. So some of the differences that I'm citing here are that we've moved from a personality disorder to disturbances. So we're saying, all right, this is still a reaction to a situation in an environment. This is a response to environmental stresses. And if someone has adaptive coping skills or they get away from the stress, then they are magically cured again and we are good to go. And if that's not the case, then there must be something else wrong and we have to have another mental disorder indicated in order to move forward with a diagnosis. I hope you're still with me in the sense of like, all right, we're understanding that adjustment to situations creates manifestation of symptoms. Cool. We are on the same page with that. We're moving away from this is a problem within your brain to this is a reaction to a situation. So we're continuing to move towards that, which then brings us to the DSM. Oh, I'm sorry. This is just breaking down those 5 phases of life that I mentioned. I do actually want to review these examples with you. So again, this is from the DSM-2, and it's broken down into those 5 phases of life. So the first one is adjustment reaction of infancy. So the example given here is a grief reaction associated with separation from patient's mother, manifested by crying spells, loss of appetite, and severe social withdrawal. Ironically, today, this may be looked at as more of an attachment issue versus an adjustment issue. Then we've got adjustment reaction of childhood. The example here is jealousy associated with birth of patient's younger brother and manifested by nocturnal enuresis, attention-getting behavior, and fear of being abandoned. So in this situation, which we see things like this today, right? When you've got a family and there is one child already earthside and born, and then parents have another baby, and you see the eldest child or the other child um, having behavior reactions to this. Next, we've got adjustment reaction of adolescence, which I don't know about you, but I think everyone probably has some adjustment reaction to adolescence. That is a very rough time in our development period. So the example here is irritability and depression associated with school failure and manifested by temper outburst, brooding, and discouragement. Again, the amount of teenagers that I work with that struggle with irritability and depression is like all of them. So it's really interesting to see this here broken down as an adjustment disorder or a reaction to adjusting when, in my opinion, which my opinion is not the only one that exists, but in my opinion, those are normal reactions to puberty, to hormone imbalances and changes, and to becoming this different phase of life where you have more responsibility and you're starting to think and feel for yourself. Um, so it's really interesting again that that's classified here as like a mental disorder. Then we've got a adjustment reaction of adult life. So there's several examples here, one being resentment with depressive tone associated with an unwanted pregnancy and manifested by hostile complaints and suicidal gestures. So this example is saying someone finds out that they're pregnant, it's an unwanted pregnancy, and their reaction to this is hostile complaints and suicidal gestures. Situational, right? The next example they give for adult life is fear associated with military combat and manifested by trembling, running, and hiding. So that falls more in suit with what they had been talking about in the DSM-1, with that being a part of World War II. Then the last one is a Ganser syndrome associated with death sentence and manifested by incorrect but approximate answers to questions. To be honest, I don't even know 100% what that means. So I'm trying to think if I was a provider when the DSM-2 was my manual, Many of these examples feel very normal and expected, right? If you're going to combat, of course, you're going to have fear associated with that. If you have an unwanted pregnancy, it makes sense that you would have complaints and feel suicidal or like there was no way to get out. Um, if you are facing a death sentence, of course, you're going to have a reaction to that. And then the last one for the phases of life for the DSM-2 is adjustment reaction of late life. The example here is feelings of rejection associated with forced retirement and manifested by social withdrawal. So in this example, someone is forced into retirement. Maybe their health is no longer able to support them working full time, and it is against their will that they have to go into retirement sooner than they were hoping. And then that manifests through a social withdrawal. That also makes sense to me, right? If you go from working every day of your life for 65 plus years and then all of the sudden you no longer have that routine, of course your socialization changes. A lot of times our friends are built into our workplace, right? So if this person is forced into retirement, they no longer have the convenience built in of seeing their friends every day at work. This again feels like an understandable reaction to a large life change. Again, we're going to keep going through the different versions. Next up, we have the DSM-3, which came out in 1980. You'll see now that the cover has changed. So the DSM-2 here is just labeled Diagnostic and Statistical Manual of Mental Disorders. You've got it broken down. It still has the same title, right? Diagnostic and Statistical Manual of Mental Disorders. But here, for some reason, the way that it is laid out looks different, right? In the DSM-2 on this slide, you're seeing like mental disorders is in huge white letters. Then when you look here, it's a little bit more blended in to the title, and it's not just this you have a disorder. Language matters, folks. That's why I'm pointing this out. So in the DSM-3 we are in 1980, and now it is finally called adjustment disorder. So this is where we've got the title that we are currently working with today in 2025, but this is the very first model of that. So in 1980, with the release of the DSM-3, adjustment disorder was finally recognized in a form based on the experiences an individual is experiencing rather than the age or developmental stage they are going through. The name was changed to adjustment disorder with this release as well. In the DSM-3, they broke it down into 8 different categories. So, as mentioned, for this version, we're moving away from this being attached to developmental phases of life or stages of life, and again, going into what is an individual experiencing regardless of stage of life. So those 8 different categories here, we've got um, with depressed mood, with anxious mood, with mixed emotional features, with disturbance of conduct, with disturbance of emotions and conduct, with work or academic inhibition, with withdrawal, and with atypical features. So now what's happening is they're saying, all right, we've got adjustment disorder as this umbrella term. And then we're noticing that people experience or manifest symptoms of adjustment disorder differently depending on the situation and the experiences being had. So we're starting to make a little bit more logical sense, in my opinion. Moving on, guess what comes next? Next, we've got the DSM-4 TR. So this is that text revision version, the fourth edition. Adjustment disorders remained an independent category here and a diagnosis, but some of the subtypes from before were eliminated. So I'm going to go backwards again. So some of the subtypes that they got rid of here are 309.23, so with work or academic inhibition, and 309.83 with withdrawal. I think that's also kind of interesting because like why those 2 categories? I'm not sure. Why did we decide to move away from that? Um, It was also noted that this remained poorly defined and there were no guidelines for the measurement of the diagnostic criteria. So folks are like, all right, I understand that this is now about a situation and not about a life phase, but how do I measure it or what am I looking for? How do I know if the symptoms have lasted long enough? What counts as long enough, right? And that takes us to the DSM-5 in 2013. Which, side note, I remember being a baby social worker. The DSM-5 was what was out when I was in grad school. And it's crazy to me that that was 2013. That's like not important at all, but it's wild to me that it feels like the DSM-5 has been around forever, but also not long at all. And this was in 2013, so over a decade ago. Um, so in the DSM-5, adjustment disorders were combined with a cadre of traumatic disorders. So adjustment disorders in the DSM-5 were placed under the trauma and stressor related disorders. Look at that, not a personality disorder, but a trauma and stressor related disorder. That feels a little bit more on target, yes? That chapter in the DSM also includes PTSD and acute stress disorder. And adjustment disorders were no longer an independent category. The hope there was that this would promote additional research, right? So the way that this was listed, 309.89 or F43.8, adjustment disorder, other specified trauma and stressor related disorder. It still did not have a timeline for duration of symptoms, which is a problem. Um, why, I'm going to ask you to ponder this question for a second, but why do you think it matters so much to have a timeline for duration of symptoms for something like adjustment disorder? I'm going to pause again for a second and let you think about that. Why does it matter so much to know the timeline for duration of symptoms? There's probably multiple thoughts here, but the thought that comes to my mind is how am I going to differentiate between acute stress disorder, PTSD, and adjustment disorder if I don't have anything to go off of in terms of timeline for duration of symptoms? One of the biggest things that sets apart adjustment disorder from acute stress disorder and PTSD is, in fact, the duration of symptoms and the timeline. Which then takes me to 2022, we've made it to the DSM-5 TR. We are in the text revision, and we now have a definition and criteria remained the same from the DSM-5. So those things stayed the same, but core specifiers were added to include acute or persistent. And now we see that the timeline of duration of symptoms being added back in. And this brings us to present day 2025. We have not had any additional DSM revisions or revisions about the definition of adjustment disorder. So from this point forward in the presentation, I'm going to only be referring to the DSM-5 TR version of adjustment disorder. But I thought it was fascinating to see how this particular diagnosis has ebbed and flowed over time through the different revisions of the DSM. We started as a personality disorder, then developmental disorder, and now finally we've made this to, all right, this is a reaction um, in response to a stressful life event or change. So that takes us to the official definition. So this is from the DSM-5 TR, again, came out in 2022. The definition here is that adjustment disorder is a mental health condition where a person experiences emotional or behavioral symptoms in response to a stressful life event or change. Because, fun fact, stressful life events and changes don't just happen in our developmental phases, right? You may have stressors and changes in every developmental life stage. And so, if you think about it in that regard, someone who experiences a stressor in every life stage, they would just continuously be diagnosed with a new version of adjustment disorder, which doesn't seem to really appropriately describe what's happening. So moving on, the diagnostic criteria from the DSM 5 TR. I'm going to read through this. It is a mouthful. So first thing, the development of emotional or behavioral symptoms in response to an identifiable stressor or stressors occurring within 3 months of the onset of the stressor. So right off the bat, here we have a time frame, which is very helpful. Two key words here to remember is stressor, the thing that happens to cause the symptoms or the response. So we've got stressors and symptoms. So then we've got criteria B here. These symptoms or behaviors are clinically significant as evidenced by one or both of the following. Marked distress that is out of proportion to the severity or intensity of the stressor, taking into account the external context and the cultural factors that might influence symptom severity and presentation. That's incredibly important as well. Different cultures handle and react to stress differently. Some cultures are discouraged from sharing when they're experiencing stress. So some of the symptoms might not be as obvious as they would be in other folks. So keep that in mind. You might have to dig a little bit deeper to see what are those symptoms or responses to that stressor. So remember one or both. So the second one being significant impairment in social, occupational, or other important areas of functioning. So if we remember back to a few versions of the DSM before, they got rid of those specifiers. So now in the DSM-5 TR, they've added the specifier of impairment with social, occupational, or other important areas of functioning into this section here. C, the stress-related disturbance does not meet the criteria for another mental disorder and is not merely an exacerbation of a pre-existing mental disorder. Whew, again, a mouthful. So we've got to explore whether the disturbance is a reaction or an extension of an already existing mental health disorder, or is this something that is directly only related to the stressor? D, the symptoms do not represent normal bereavement. So it's not in representation of like this is a normal reaction or a normal amount of grief. E, once the stressor or its consequences have terminated, the symptoms do not persist for more than an additional 6 months. So let's say the example earlier of the person in adult phase of life who found out that they had an unwanted pregnancy and they were feeling suicidal. If, let's say, a plan was created for what was going to happen with said unwanted pregnancy, this person comes to the plan, everything is, for lack of better words, worked out, or a plan has been created, all is fine, everything's good to go. If that person is still 6 months later experiencing the same amount of distress from that unwanted pregnancy, even though it is no longer a stressor in their life for whatever reason, that would be something to look further into. So again, those keywords, stressor and symptoms. So some examples here of identifiable stressors. So when you are trying to distinguish if this is related to a present day stressor or if this is related to an already existing mental health disorder, here are some things to think about. So some identifiable stressors, we tried to come up with ones that would impact a variety of people, ages, populations, and cultures. So, ending of a relationship, this is a huge stressor for folks. Your entire life basically flips upside down, and sometimes it feels like it happens overnight. That's definitely an identifiable stressor. Similarly, marital problems and or divorce, again, flips your entire life upside down. When your home life doesn't feel stable, it feels almost impossible for anything else to feel stable. Moving, are you relocating? Are you even, for example, I just moved from downtown Kansas City to a rural neighborhood in Missouri, and that is a stressor in the sense of like my entire day-to-day world feels incredibly different. The hustle and bustle of downtown to the quiet, reservedness of rural communities, it's just incredibly different. And so moving is a stressor, right? Also, if you have ever moved in your life, you know that moving is incredibly expensive, it's exhausting, it's taxing, you can't find your toothbrush. It's horrific, right? Naturally you are going to have an increase in symptoms to that stressor. Loss of a job is another example. Again, your livelihood is being threatened in this way. If you have loss of a job, you're not sure where your income's going to come in from. That in itself is a stressor. Finding another job, trying to provide for your family, feeling like a failure, et cetera, et cetera, et cetera. Separation experiences. These are just some random examples, but maybe a parent or a partner gets drafted. Someone that is close to you or important to you is in the National Guard and gets drafted. That's absolutely a stressor. Another example might be your partner going on a work trip. That may be a very short-lived stressor. Let's say it's a week-long work trip, but if you've never experienced that before, or you have a history of feeling abandoned, or you have a history of being cheated on, or whatever the case may be, the identifiable stressor would be the partner going on a work trip and feeling that separation leading to symptoms in reaction to the stress. Migration, someone's refugee status. I think the world that we live in right now makes this incredibly stressful. Changing schools. So if you're working with an adolescent, even the normal change of going from elementary school to middle school might be a stressor for some kiddos. Of course, changing districts would be a totally different stressor. Gaining a sibling, I gave that example earlier. Becoming a parent. I work with many first-time parents in my therapy practice, and your entire routine changes. Everything that you knew about life once as it was is completely different once that baby comes earthside. That is a stressor. That is something that people might have reactive symptoms to. Not meeting a desired goal. Maybe you didn't pass your licensure exam. Knock on wood, if anyone's out there studying, you got this. But let's say, yeah, you didn't meet this desired goal of passing your licensure exam, and now you're thinking, oh my gosh, my whole life is over. Can I even be a social worker? Is this even something that's going to work out for me? So on and so forth. That stressor then might have symptoms. And then retirement, we talked about that example earlier as well, of when someone gets into retirement, they have to figure out what to do with their time. They lose that sense of purpose or like, who am I? What am I doing here? Those types of questions start becoming more common, and that's maybe a new experience for someone stepping into retirement. There's about 1 billion and 1 different stressors because, to be honest, the stressor is not necessarily something that will be the same across the board, right? Like something I view as a stressor might not be stressful for my client. Something that my client is experiencing stress about may not have been something that crossed my mind. So I always like to check in with my client and just ask, what have been some of the biggest stressors in your world lately? What things have created a change in your day-to-day life? That's going to help us better understand, again, is this a situational thing, or is this maybe an exacerbation of a pre-existing mental health disorder? So in the DSM, 5 TR, we've got the breakdown to specify symptoms, right? So you've got all of your different adjustment disorder categories. You've got 309.0 or F4321, adjustment disorder with depressed mood. So there's been a stressor. There is symptoms in response to the stressor, and depressed mood is overarchingly what those symptoms are presenting as. Then you've got F4322, adjustment disorder with anxiety, same idea, except for instead of those symptoms manifesting in depressed mood, they're manifesting more from a place of anxiety. Then we've got F4323, adjustment disorder with mixed anxiety and depressed mood. This is exactly what it sounds like. You've had a stressor, now you have symptoms, and the symptoms are a mix of anxious symptoms and depressed symptoms. Then we've got F4324, adjustment disorder with disturbance of conduct. So that a disturbance of conduct is like um, stealing or theft or breaking the law or breaking rules in general. Um, then moving on, F4325, adjustment disorder with mixed disturbance of emotions and conduct. So maybe you've got someone who is struggling to manage their emotions in reaction to the stressor, and that is coming out in disturbance of emotions and then also the conduct as before, breaking the rules, things of that nature. And then, of course, F43.20, we've got adjustment disorder unspecified. That's where we just can't quite fit it in any of these categories. We know that it is an adjustment disorder because it is a reaction to a specific stressor within the last 3 months, but we're still unspecified as to what those symptoms are displaying as. So, a fun fact about specifiers is that the F codes are in order in the DSM. The way it is presented on the slide is exactly how it presents in the DSM. So you've got 21, 22, 23, 24, 25. It is interesting to me that 20 is at the bottom, but because it is unspecified, that sort of makes sense. Woo! Mouthful. I told you, we've got lots to learn today. All right, so now we are going to look at some of these subtypes. Um, so F4321, adjustment disorder with depressed mood, is the most common subtype. So this shows up as low mood, tearfulness, or feelings of sadness are predominant. So as mentioned, you've got the stressor, then you have the symptoms in response to the stressor, and they are showing up more so in these ways. So low mood, tearfulness, feelings of sadness. Example here, client loses their job and reports spending more time alone and loss of hope for finding a new job, difficulty with motivation and focus, client is sleeping more than usual. Right off the bat, this is riddled in depression, right? So you've got spending more time alone, isolation, loss of hope, lack of motivation and focus, sleeping more often. Gorgeous example of exactly what that would look like in real life. Then we've got with anxiety, so F4322, adjustment disorder with anxiety. Cheers if you're a coffee drinker. I need a coffee break. So this is going to show up as nervousness, worry, jitteriness, or separation anxiety. The example we're giving here is a client experiences a breakup and reports having many racing thoughts and worries while fidgeting in session. Difficulty sleeping and staying asleep in the past 4 months, and ruminating is specific to the breakup. So let's identify our anxiety symptoms here: racing thoughts, worrying, fidgeting, difficulty falling asleep and staying asleep, and rumination specific to the breakup. I love that these examples are so just perfectly described. Now we've got the mixed anxiety and depressed mood. So of course that is a combination of depression and anxiety being predominant. The example that we are working with here is that a client's partner has been deployed for the military and client presents with isolation and worrying often. Sadness is the emotion felt when thinking of the client's partner being gone, but this is intermittent depending on what the client is doing or focused on. So here we've got the mix of anxiety and depressed mood. So the client is isolating more frequently, but also worrying more. So isolation falls under depression, worrying falls under anxiety. Sadness is the overarching thing that this client is identifying that they feel when thinking about their partner being gone, but also it appears that they're able to distract themselves sometimes because it's intermittent depending on what the client is doing or what they're focused on. Next, adjustment disorder with disturbance of conduct. So, disturbance of conduct is predominant, and that I mentioned this earlier, but a better, a more clear definition of disturbance of conduct is a pattern of disruptive behavior that violates social norms or the rights of others. Some examples of that might be aggression, destruction of property, lying, theft, and breaking rules at home, school, or work. The example here, a teen client recently switched schools and begins drinking alcohol and lying to adults such as parents or teachers. So let's break that one down. Recently switching schools, there's our stressor, there's our adjustment, and then the behaviors such as conduct in this example, drinking alcohol counts because that violates the social norms of a teenager, and then lying to adults would be another conduct disturbance. Next, adjustment disorder with mixed disturbance of emotions and conduct. So I mentioned this earlier, but this means that both emotional symptoms, depression and anxiety, are showing as well as the disturbance of conduct. The example here, a child client, has been removed from their home and parents due to unhealthy living conditions. So there's the stressor. They display an increase in hitting and kicking their teachers and stop playing their favorite sport while isolating in their room more often. So here we've got the isolation falling under depression. You've got we can imagine that this client is experiencing anxiety if they were removed from their home and their parents and they were in unhealthy living conditions. They're thinking, what's going to happen? Are my parents okay? Will I ever see them again? Et cetera, et cetera, et cetera. And then the response to the stressor is the conduct, so increase in hitting and kicking, and then the withdrawal symptoms of isolating and not playing their favorite sport any longer. Now we are at the unspecified or the last subcategory that's in the DSM-5-TR for maladaptive reactions that are not classified as one of the specific subtypes of an adjustment disorder. The example is a child client was brought to therapy by their parents, being proactive about them gaining a new sibling. No symptoms have been identified yet, but we are trying to stay ahead of, hey, this new stressor is coming down the pipeline. What can we do to prepare for that? With the understanding that there may be symptoms as a reaction to that stressor and change. Also, we love a proactive parent, A plus. All right. So, I've talked quite a bit about the need for a specification for duration and timelines. Um, so this is broken down into acute and persistent or chronic. So by definition, symptoms cannot be persistent, or excuse me, by definition, symptoms cannot persist for more than 6 months after the termination of the stressor or the consequences of the stressor. The persistent specifier therefore applies when the duration of the disturbance is longer than 6 months in response to a chronic stressor or to a stressor that has enduring consequences. So, acute, this specifier is going to be used to indicate the persistence of symptoms for less than 6 months. So, that's acute. And then persistent or chronic is going to be used to indicate persistence of symptoms for 6 months or longer. But again, that is that applies when the duration of the disturbance is longer than 6 months, but it applies to both chronic stressors. Chronic stressors means repeat, that is persistent, that is chronic. Or the stressor has enduring consequences. So enduring consequences are like this stressor happened, i.e., parents having another baby. That has consequences that last for a lifetime because that baby is like now a new part of your life that is forevermore there. I hope that is clear as mud. Um, Prevalence of adjustment disorder. So what we know is that adjustment disorder affects about 5 to 20% of individuals seeking outpatient mental health treatment. Children and adolescents are more often diagnosed with adjustment disorder than adults. And some risk factors to consider are low support networks, other mental health conditions, and lower socioeconomic status. For children and adolescents, a clinician is more likely to see adjustment disorder as disruptive or a marked change in behaviors, whereas for adults, they're more likely to display their symptoms as mood and affect. Reminder here is that kids don't always have the language to describe what they're feeling, but all behavior is a message. Some trends here. Here's a little graph for you that graphs that diagnostic prevalence of all of these different mental health disorders from 2015 through 2024. So this between 2015 and 2024, the rate of anxiety and adjustment disorders did slightly increase, while depression and substance use disorders notably decreased. In more recent academic years, because this is looking at college mental health, 2023 and 24, anxiety, adjustment, neurodevelopmental, and OCD related disorders were at their highest prevalence rates, while depression, substance use, and bipolar were at their lowest. And you can see their adjustment is that pink line. So you can see how that's kind of ebbed and flowed just a little bit over the last 10 years. So some differential diagnoses to keep in mind when you are working with someone possibly struggling with adjustment disorder. Major depressive disorder, again, if you're seeing more of those depressive symptoms, post-traumatic stress disorder, and acute stress disorder, I always recommend cross-referencing all three of those. If you're looking at adjustment disorder with someone, it's definitely important to make sure they don't meet criteria for either of the other stress-related disorders. Personality disorders, bereavement, psychological factors affecting other medical conditions, and normative stress reactions. So, assessing for a history of the client related to depression and anxiety symptoms over their lifetime may lead to a different diagnosis, even if the client is stating that the stressor caused the current symptoms. So, for depression, major depressive disorder may be a more appropriate diagnosis if the client is attributing the negative thinking pattern as focused on more existential sense of hopelessness versus based on only the identified stressor. The repetitive or chronic nature to the level of depressive symptoms can also help to provide a differential diagnosis. PTSD timing and symptom profile considerations are going to be the most important there. With personality disorders, you want to assess if there's been a history of personality disorders. Um, and then for normative stress reactions, you're going to be again thinking about like that impairment in social, occupational, or other important areas of functionings that don't seem out of the norm. That's what you're kind of looking for here is like, oh, this stressor happened to you. It makes sense that you would be having a hard time, right? So this is more so making sure that the symptoms that are being displayed are more quote unquote extreme than normal based on the situation. The other thing there is, of course, making sure the time frames and periods are met for adjustment disorder. All right, moving forwards, we've got some assessment tools here. The next several slides are going to show you these different adjustment disorder assessment tools. I'm not going to like read every single one of these to you, but I do think it's important to notate that there are three different scales, and they are self-report, and they do come in 12 different languages, which is awesome. So the International Adjustment Disorder Questionnaire, or the IADQ, can be found at that link there. And then there's also the Adjustment Disorder new module. There's the 4, the 8, and the 20. So this here is that IADQ, and this is, as mentioned, self-report. So you have got all of these listed, and it says, I am currently experiencing, and then it asks you all of these things here, and it's literally just a yes checkbox question. Then you'll see the second page there. It's broken down into not at all, a little bit, moderately, quite a bit, and extremely. You only move on to this portion if you selected yes to any of the things listed in section 1 through 9. And then finally at the bottom there, questions 17 through 19 are broken down into the past month specifically. So how much have you been bothered by these things in the past month? Next, you will see the ADNM. This is just an 8 question, the 8 questionnaire here. So you've got the list of stressful life events, and then it says, please indicate those events that happened during the past insert time frame here. So depending on what you are trying to assess, you can break it down into time frame, and then it also talks specifically about the last 6 months. And on this, again, self-report, and then we go into the second half, which is how often are these things showing up for you. So never, rarely, somewhat, or often. And then I've got the ADNM 20. Same idea, but a more extensive scale. Um, the more extensive the scale, the more likely you are to get more information. So if you're feeling a little bit stuck or like you're not totally sure, it might be helpful to use this one since it has a lot more questions about the frequency during the last week and how long they've been experiencing the symptoms. So I really appreciate that on the second half here. It's got the frequency during the last week and it's got 20 questions there. But then also asks how long, whether it's less than a month, 1 to 6 months, or 6 months to 2 years, which is going to help you with that time frame in your differential diagnoses. Some treatment guides. So you're going to be looking at different options for children and adolescents versus adults. As mentioned earlier, children and adolescents experience adjustment disorder more frequently, and they also are showing symptoms more often through the behavioral or conduct type reactions. So some things here that can be helpful um, is non-direct child-centered play therapy. So that is play therapy for children where the child is in charge. That also gives a sense of power and control, which can help someone feel a little bit less anxious. Direct play therapy, of course, art therapy, and using CBT. So, treatment concentration for both children, adolescents, and adults is focused on building coping skills, increasing resilience, and developing a larger support network while returning to that pre-stressor baseline. Processing of the emotional toll of the original stressor and the impact on self are also incredibly helpful and important. So on the adult side here, CBT is something that's recommended for treatment for adjustment disorder. It's going to be focusing on identifying and changing negative thoughts and behaviors that contribute to said symptoms. Then we've got ACT. That's going to help build psychological flexibility through acceptance and taking action based on the client's personal values. With using ACT or ACT for adjustment disorder, there's an emphasis on building a meaningful life which provides hope. So again, stressors, I'm thinking back to the stressor of like losing a job in the example where the client said that they didn't have hope for finding a new job. Using ACT would be helpful in that example there to then use those personal values to create goals for a meaningful life. Interpersonal therapy is also helpful. That's going to explore how relationships and social interactions might impact the adjustment. So, are other people a part of the adjustment? We mentioned several stressors earlier that definitely involve interpersonal relations. So, interpersonal therapy would be great for that. Family therapy or group therapy is always helpful. This involves family members in the treatment process to improve communication and support. Some stress management techniques. I apologize, I'm kind of bouncing all over the place. I want to make sure that I give enough examples for each, and then I get ahead of myself. But stress management techniques like breathing, mindfulness, and grounding are going to be helpful for adults. And then medication is listed here as well. I just want to notate that sometimes that is used to help increase mood and or decrease worry and rumination. Duration of treatment for adjustment disorder can last up to several weeks or up to several months. If medication were to be used, it may be something that is used PRN or as needed, or maybe it is only used in a short period of time while the person is working through the aftermath of the adjustment. Phew! That was a whole lot of information. A whole lot of information. Moving us to our references here, there's a whole bunch for you. I hope that you learned something. I realized that I ramble and gave a whole lot of information. The main things to remember here again are the timeline. So, is this in reaction to something that happened within the last 3 months? Has this person been experiencing symptoms for more than 6 months? And is this a quote unquote normative reaction to an adjustment? So there's a lot of different things to consider. Adjustment disorder is definitely something that has a place, right? It is, we work with folks all of the time that maybe have never experienced anxiety or depression in their entire life until there was a stressor that occurred. That is definitely something that happens. People's lives change every single day for differing reasons, and everyone reacts, and those emotions manifest differently depending on your um, lived experience and other personal um, perspective. So, thank you again for spending time with us today. We hope that you learned something. Reminder that there are 6 CEUs for Care for You 2 2025. I highly, of course, encourage you to watch all 6 of them. There's some really great content this year, and we are so grateful to have you. Thank you again, and thanks for choosing to be a part of Care for You 2.